Hello everyone, welcome to YouTube channel Log Easy Medicine 003. So today in this video we're gonna study about a case study on a patient present to us. So he is a 58 years old male patient, presents with hematemesis for the past 2 days. He complained of several episodes of epigastric pain for the past years as well. So before I discuss further on, I need to confirm that this video not consists of the details of systemic review and physical examination. Okay, so once a patient has arrived to us with a complaint of hematemesis, so we need to have in mind that hematemesis comes under the upper GI bleed. So I have a differential diagnosis here, and then we need to have a broad differential diagnosis in our mind as well. So to make it simple, we can divide it as into varicose bleeding and non-varicose bleeding. So if it is varicose bleeding, it is more common for the liver pathology under the portal hypertension. If it is non-varicose bleeding, it comes from the maybe esophagus or stomach most commonly. So under the non-varicose bleeding, we have this esophagitis, esophageal carcinoma, miliary waist tear, peptic ulcer disease, gastric carcinoma, and then the other one is not under the it is under non-varicose bleeding, which is dental issues, because usually the patient may complain of they woke up in the morning and then they complain of I vomit out blood after I woke up. So we need to ask the patient where exactly the blood comes from. So that's how it differs. So we move to the history taking. So for the history taking, you usually use the Socrates. So we start from the site where exactly the blood originates. As I mentioned before, it can be from the mouth or maybe from the stomach or esophagus. So we need to ask the patient regarding this one. And then the next question is when it started. Was it like sudden or gradual? And then we need to confirm the patient whether it's like first episode or previously they had the similar complaint. So once done with that, we move to the character. So for the character, we need to ask regarding the hematemesis, what was the amount, color, and then was it like persistent or intermittent or just stops after one episode. And then next is about the associated symptoms. So hematemesis won't come alone. It comes with other symptoms as well. So we can ask for the vomiting, very important, because and then with the details of the vomiting as well, because if the patient vomited like many times, we need to stabilize the patient as well, correcting the electrolyte imbalance. And then regarding the abdominal pain, which is very important as well, because the patient has complained like epigastric pain for the past years. So we need to ask the details as well, how we manage the pains all the time. And then next is about the dysphagia, dyspepsia, odinophagia, heartburn, jaundice, and other bleeding. Very important as well, because patient may having bleeds from the lower GI and also maybe from the dental or maybe from the nose. It's very important to ask regarding this one. And then we need to ask what he does to control the bleed from the hematemesis. Does he took any medication, or does he visit any clinic or any that's what we need to ask. Next, we need to ask how long it was lasted. We need to check for the duration. And then next is about the condition, whether the hematemesis worsened by any of the conditions, like after drinking hot beverages, taking fatty or spicy food, or any particular position provoked the condition, the hematemesis. Next is about the severity. So as a patient has complained of this vomiting, blood, and so on, so we need to ask the complication of this blood loss, whether maybe syncopal attack, chest pain, fatigue, palpitation, dizziness, and so on. So once done with the history, we need to ask the risk factors as well. So what are the risk factors can cause this upper GI bleed? The first one is continuous vomiting, and then alcohol abuse. Both these conditions can actually cause the miliary waist tear. And the next is about the NSAID use, smoking, taking spicy fatty food, or increase take of the smoked food like satay, because all these condition actually like sort of enemy for the esophagus and stomach. So we need to ask the one. And then next is about the food preparation and basic hygiene, because usually the peptic ulcer is commonly associated with H. pylori infection. So we need to ask the patient where usually they eat, and then how it prepared, and then we need to ask for the water supply, whether they are living in a crowded area, and so on. Next is about the previous stomach related problems. Maybe the patient may be having besides this epigastric pain, he might be having like regurg or any sort of like dysphagia and so on. So we need to ask the details about it, and then how it was treated and so on. Next is about the occupation, which is asbestos, asbestos and mining, because this condition can cause the gastric carcinoma. And then next is about the focused family cancer. Previously the patient's family had any gastric cancer, stomach cancer, and so on. And then we need to ask the patient itself, like whether he had previously got any cancers, and then how it was treated, or still having it, and on any medications, and so on. Now the last one is actually the dental problem, so we need to ask the one as well. Next is about the investigation. So for this case study, I'll just write down the definitive investigation, what we can do for this patient. So the first one, very important one, is the OGDS. So for this OGDS, it can be help us for the diagnostic and therapeutic purposes. If it is diagnostic, it can actually help us to see for the active bleeding, any mass, any tumor, any redness, swelling, and any we can actually take biopsy as well. For any sort of pathology, we can identify it. Next is for the therapeutic, we can actually stop the bleeding via various techniques. And the next is barium swallow. And then the next one is chest x-ray. We can actually check for perforation, and then metastatic condition like cannibal appearance of the lung from GI cancers. Next is about the CT and endoscopy ultrasound, which this investigation done for the cancers, most commonly done in the cancer situations. Next, we're going to discuss about the definitive management for each pathology. So once we got to know the history, physical examination, and then we are done with the investigation, we are actually more close to the diagnosis. What could be the reason for this patient having hematemesis? So I have divided here the management part for each pathology, which is very brief. Okay, so for the mallory based tear, we can actually stop. Usually this condition stops by own. If not, we can actually do the epinephric injection or hemoclipping by the OGDS. Next, if it is if we rule out esophageal carcinoma, we can actually do the modified Eifer-Lewis-McKeown. If it is esophagitis, most of the condition can be treated under medical treatment. If it is severe and then the patient is like very ill, we can actually do the surgery as well. Next is peptic ulcer disease, which further classified into perforation, bleeding, obstruction, which is the complication of PUD. So if it is suspect for the perforation, we can actually do the suturing. If not, we can do the Billroth 1-2. If it's bleeding condition, we can actually do the Billroth as well. If it is obstruction, we can do the truncal vagotomy. And then the last part of this video, which is gastric carcinoma, we can actually do the gastrectomy, maybe total or subtotal. If it is total, it is due to the lesion in the proximal part of the stomach. If we do the subtotal, in conditions the lesion is distal part of the stomach, plus with the Roux and Y gastrojejunostomy. I'm not sure about the details. You can actually you can see the videos and how it done. These are about the very brief discussions on patients present with hematemesis. Hope you guys like this video. If you like this video, please don't forget to give some good comments, share among your friends, and then please subscribe the channel. Thank you so much.